Asthma is a complex chronic disease affecting approximately 24 million people in the United States. It leads to roughly one emergency department visit every 2 minutes. Despite advances in respiratory care, a gap persists between best practices for asthma care and the care that patients receive. I'm Andy Reynolds. Today on Quality Matters, we're discussing what's happening and what's possible in asthma care. My guest is Tonya Winders, President and CEO of the Global Allergy and Airways Patient Platform, or GAAPP. Tonya, welcome to Quality Matters.
Thank you for having me. Excited to spend some time together today.
Why don't we start by having you tell us what GAAPP is and how you came to be its CEO?
It's a winding way of about 25 years. GAAPP is 175 patient advocacy groups all over the world in respiratory and immunology. I've always been in the respiratory and immunology field. I spent about a dozen years in marketing and strategic partnerships and managed market access. I worked with patient organizations, professional societies, and payers to ensure access to treatments. At the same time, I am the mother of 5 adult children. 4 live with allergy, asthma, you name it. So 12 years ago, I had the opportunity to become the president and CEO of the U.S. organization, Allergy and Asthma Network. And 2 years ago, left that position to become the CEO of GAAPP.
We're speaking in May, which is Asthma Awareness Month. So it seems fair to ask, what are most people not aware of, or what do most people not understand about asthma care in the U.S.?
The most surprising thing about asthma care is about half of patients do not have controlled disease on any given day. And what does control look like? No symptoms, keeping them from doing their daily activities of living, enjoying life like you or I who live without asthma are. It's surprising for most people to learn that about half of those diagnosed are not well controlled.
What do you think the number should be? I don't know if 100% control is realistic, but 50% sounds low. Where do you think it should be?
Over 90% of people should be able to live without daily symptoms on the type of medicine. If they have the right diagnosis, right treatment, right management, they should be able to live pretty symptom-free. We think it's about 5% of the overall asthma population that has truly hard to treat asthma that we still need innovation and new solutions for.
It sounds like you believe 95% of people who have asthma have the kind that should be controllable.
Yes. If appropriately diagnosed, treated, and managed. And that is a big if, because unfortunately, most people don't get access to the basics of diagnosis and treatment and really don't know what it takes to manage the disease. If we always could say that we get the right diagnosis, the right treatment to the right person at the right time without the barriers of our fragmented health system, it would be. But unfortunately, that's not the case. We live in a fragmented system. It takes on average well over a year for someone to get that accurate diagnosis. If they are then uncontrolled, it takes 1 to 3 years to see a specialist. That would be a pulmonologist or an allergist. Then it takes an additional year to determine if they're not taking their inhalers correctly. About 70% of people don't take them correctly, which is shocking. Or they have that more difficult to treat that needs advanced therapies like biologics. And then which biologic is going to work best for them. So the typical journey of a moderate to severe asthma patient in the United States is 5 to 10 years.
Wow. Starting with 1 year just getting diagnosed?
Yes.
Why is that? What makes diagnosing asthma difficult?
Asthma diagnosis, first of all, if done according to best practice and guidelines, it's done with the definitive diagnostic tool, spirometry. We've got limitations in access to spirometry. Only about a third of asthma patients have ever had spirometry. So what does that mean? They're getting a diagnosis without the gold standard of diagnostics. It's done by a differential diagnosis rather than a definitive diagnosis. So the first step is getting that, for sure, this is what you have, asthma.
You mentioned Differential versus definitive diagnosis. Can you tease that apart for us, please?
Most of the time, this happens in primary care. Someone comes in, they're short of breath, they're wheezing, they can't do activities they want to do without becoming winded. A lot of times, physicians just ask the questions about, do you cough, do you wheeze, do you wake up at night, those sorts of things, and make the diagnosis based only on the symptoms, versus having that definitive diagnosis with a spirometer, a lung function test that tells us, do your airways reverse when you take a bronchodilator? If you have asthma, when you take that bronchodilator, the airways loosen, that squeezing of the airway stops, and you're able to push through more air. That's the definitive diagnosis versus a differential diagnosis.
I hear a lot about childhood asthma. How does the patient's age affect getting an accurate diagnosis?
If asthma is onset as a child, someone is more likely to be diagnosed sooner. The parent is noticing those symptoms and getting them to see the pediatrician, getting that diagnosis. As an adult, we tend to put our healthcare on a back burner. We adapt and normalize. We make excuses for we're getting older, perhaps we're out of shape. A lot of individuals that have higher BMI have asthma. So they don't know if it's just because of their weight, if it's truly their lungs, or they have cardiovascular disease and they begin to think it's the heart, because that tightness in the chest can kind of mimic heart disease, and fatigue and shortness of breath. All of those things are oftentimes symptoms of heart disease.
It sounds like there is a stealthiness to this disease, meaning it can masquerade or look like other conditions.
Yes, we see that commonly. Another respiratory condition, COPD, chronic obstructive pulmonary disease, is close to asthma. The differential diagnosis between asthma and COPD is the reversibility. When you take that bronchodilator, that medicine that makes the airways relax, does it reverse or not? You can get the inaccurate diagnosis on both sides, asthma and COPD. And sometimes we see people that have both, have some reversibility, but not complete reversibility. So that's one reason. Cardiovascular, we've already talked about. Again, obesity. We see a lot of people that have comorbid obesity and asthma. So teasing that out oftentimes takes more than a 7 to 10 minute primary care visit. And that is really the norm here in the US. We've got limitations in access to time of that clinical encounter. So it sometimes takes us taking more time asking the right questions. It also may take going to a specialist to get access to those definitive diagnostic tools.
Okay, to recap, things that make diagnosing asthma hard include access to the true test, spirometry, complications of age, especially as people develop other comorbidities, and time, or the time limitations of an office visit. What else?
We lack informed providers. We have a great need for upskilling our primary care providers. Everyone's not staying up on the latest science. Everyone's not reading the medical literature. The average age of the provider is well into the 50s, 60s in many areas of the country. So if you weren't trained on these things in the last decade, you have no idea of the developments that have occurred.
Let's assume you get that definitive asthma diagnosis. Then what? What are the hallmarks of high quality treatment?
The mainstay is what we call inhaled corticosteroids. That's the inhaler that one should take pretty much daily to keep inflammation in the airways manageable. And the second is a bronchodilator. Asthma is a two-sided coin. Inflammation and bronchoconstriction. All that means is that your airways twitch and tighten over time. So you need basically a muscle relaxer for those airways. So you need something to fight the inflammation and something to make the airways relax. That's the two-sided coin of asthma treatment.
You mentioned doctors who were trained decades ago may be behind on new developments. What do you mean? What are they missing?
Care in asthma has evolved dramatically, especially over the last decade. Inhalers, they've been around, they've been managing people's disease pretty well. But there was a segment of people living with the disease who weren't managed well. About 15 to 20% of people needed something more than just those mainstay inhalers. We had the first targeted, tailored treatment called a biologic about 20 years ago, but then it was a whole decade before any other biologics came along. These biologic treatments began to come online, and over the last 5 to 10 years, we now have over 6 different biologics that have been approved for treating moderate to severe asthma that doesn't respond to inhalers. So we're getting much more tailored, personalized medicine. That's how we've seen that 15 to 20% that couldn't be well managed now being about 5% if they're on the right treatment.
I'd like to shift now to my main mental model of asthma care, and it comes from a 2024 white paper that you helped NCQA write. It's titled Improving Outcomes for People with Asthma, Challenges and a Call to Action. We'll link to that document in the show notes. And I like that paper because it presents a simple three-pronged model for effective asthma care. The three prongs are access, clinical care, and patient-centeredness. Can you tell me how those elements come together and why they matter when it comes to asthma?
I love that three-legged visual because it's very true. Number one, we have to have access to well-educated, informed providers that have also access to those diagnostic tools, right? So access is paramount. And then when people are not controlled or well managed in primary care, we need access to specialty care and to those personalized treatments. Access is a leg we cannot miss in that three-legged stool.
Got it. Access is the must-have. What's next?
Next, clinical care. As I said, 95% of patients, if they get that access to good clinical care, should be able to live pretty free of asthma symptoms. You should never have to go to the hospital because of asthma if you're well controlled and well managed. So that clinical care of knowing I have asthma, I know the medicine I need to take daily. I know to avoid triggers that make my asthma worse. And I know what to do if my asthma does get worse, how to escalate care. So clinical care is at the heart of good asthma management.
We've covered access, we've covered clinical care, just one leg to go.
Yes. Finally, patient centricity. As a patient advocate, this speaks to why there are oftentimes breakdowns in asthma management. Patient-centered communication is not always at the forefront of the way asthma care is delivered. I spoke earlier about the less than 10-minute visit, right? You and I have already been talking for some time, and there's no way we could have covered all of those things in less than 10 minutes.
What's different about asthma, though? Is the importance of patient-centered care somehow more true in asthma than with other conditions?
All chronic conditions need this patient centricity of understanding a person's life and how they can manage this chronic condition in everyday life. It is only in situations where we understand the complexity of the disease and the importance of holistic management that we get the best outcomes. The complexity and heterogeneity of asthma makes it a little more tricky. There's no asthma number like diabetes or your blood pressure. You've got that definitive number. You know what to do when you're out of range. That's not the case when we come to asthma. It's kind of hidden, and there is no readout at home to say, is my asthma out of control? Am I breathing optimally? Am I doing things I would like to be doing? Walking upstairs, playing with my kids or grandkids without breathlessness. Yet so many people living with asthma just accept breathlessness as part of life.
How could policy help with patient-centered care or patient centricity?
Number one, we need national action plans for chronic conditions like asthma. You'll be surprised to hear there has not been a national action plan for asthma in the US in decades. Having a national plan with quality standards that are reinforcing evidence-based care providers should be giving and what patients should be expecting. That's number one. Number two, when we talk about access, how do we work within payer records to identify high-risk patients and allocate resources to those patients? We're not looking at oral corticosteroid use. We're not looking at overuse of SABA, short-acting bronchodilators, albuterol, but we could put pharmacy flags at the payer level or at the pharmacy that would identify an out-of-control person living with asthma and indicate someone who's more likely to have hospitalization or death.
You mentioned developments over the past 5 years. When I think about the last 5 years, I think of another respiratory illness, COVID. How has COVID changed how you think about asthma, if it has at all?
COVID was a wake-up call. It made us aware of our lungs. We will take 20,000 breaths today, and if you don't have asthma, if I don't have asthma, we don't think about it. Our lungs do the work without us thinking twice. But for people who live with asthma, every one of those breaths, especially when they have uncontrolled symptoms, is conscientious. So COVID provided an opportunity to wake up and to make us more aware of our lung health. Number two, during the pandemic, we had an awakening around health disparities and the need for health equity. The burden of disease and mortality is higher in African Americans and Hispanic Americans. And why is that the case? It could be environmental factors like exposure to pollution, exposure to allergens are higher in those populations. Number two, access to care is a major social determinant of health. Are you getting access to quality food, to education, to primary care, to specialty care? These things play into, is someone going to get care regardless of where they live? Your zip code has much more influence on your level of care than pretty much anything else when it comes to asthma.
To augment what I was learning from Tonya, I went to the doctor who reads NCQA's work on asthma care.
Hi, I'm Caroline Blum. I'm Assistant Vice President at NCQA. I'm a geriatrician and palliative care doc, but also have done a lot of primary care. My responsibilities at NCQA involve measures and complex patients and people with multiple chronic conditions.
Caroline, what did you hear from Tonya that you'd like to double down on or emphasize?
The idea that the clinicians don't know enough. Clinicians need education. We pay a lot more attention to knowing heart disease and diabetes. We haven't paid attention to the respiratory diseases, particularly asthma and COPD. I don't really know why that is. And it's a very interesting idea, perhaps because asthma is a condition of children. Sometimes in our societies, we think most children are healthy, so we don't really think about when they have diseases. And just because they have a little bit of wheezing on and off, it's allergy season or something like that, and we just haven't paid a lot of attention to asthma in children. And in adults, people with COPD can have asthma. They're very related. And of course, we think that it could be their fault because they smoked. So I think our lack of attention might be related to the fact that we sort of say, well, it's their fault they smoked. But first of all, a lot of people have asthma who never smoked, and people have COPD who never smoked. Another reason I'd be interested in other people validating for me is the medications that control asthma and the medications that are helpful for COPD came later. We've had other medicines, but there weren't many, and they didn't work very well. So we didn't feel confident in the armamentarium of medications that could control symptoms. The good medications developed later. We have them now, but we didn't have them 25 years ago.
Where is NCQA's quality measurement headed when it comes to asthma?
We are very involved in respiratory health. We think in pediatrics, we need more attention to quality, and asthma is the major chronic disease of children. So we have some strong teams and a lot of staff working on asthma. We have multi-pronged strategy, care coordination, appropriate use of medications according to guidelines, stewardship of medicines that are maybe too strong or not appropriately used. Our newest measure coming out is about coordination of care and following up people after they've had an acute episode or an asthma exacerbation. But that's just one way to look at it. We also want to look at medications that try to drive care to use powerful medications like systemic steroids in a responsible way, which means hardly ever using them. And so those are the two directions. And we also are interested in preventing asthma exacerbations and making sure people have high quality of life. So a measure may be a patient-reported measure about were they educated, or a measure that has to do with appropriate medications based on guidelines.
And that coordination of care measure is coming when?
That measure was just approved by our voting group, the Committee for Performance Measurement, and that will be in HEDIS 2026.
Tonya, I'd like to close out our time by asking you 3 related questions. Please give us the rose, the thorn, and the bud in asthma care. By rose, I mean, what's the part that's working well in asthma care?
The rose is we realize asthma is a spectrum of disease, the personalized treatments, getting a better understanding how to address the underlying inflammation and pathway causing the inflammation is the rose. It's only been in the last 10 years, the last 3 to 5, that we've had enough approved treatments that we can really get the right treatment to the right person at the right time.
And what is the thorn in asthma care, or what is the sticking point, or the thing that's not going well?
The thorn in asthma is getting the appropriate, accurate diagnosis in a timely way because everything hinges on it. That delay is too lengthy, takes far too long, and oftentimes people are misdiagnosed. If we don't get the accurate diagnosis of the type of asthma you have and what causes your asthma, then there's no way to appropriately treat it.
What is the bud in asthma care? And by bud, I mean the future possibility. What is the opportunity we should look to next?
The bud is remission. We are finding in that moderate to severe category, when they are diagnosed accurately and get appropriate access to targeted treatments, about 1 in 3 go into a clinical remission where they have no exacerbations, no symptoms, no hospital, no ER, no oral corticosteroids, no use of short-acting bronchodilator. This is something that I have to tell you, I never dreamt would come in my career. So it's a very exciting time, especially for those that have had the opportunity to access these miracle drugs. That's the term they use, miracle drugs that have changed their lives and given them the freedom to breathe.
I think that's a good place to leave it. Tonya Winders, President and CEO of GAAPP, thank you for being part of Quality Matters. We appreciate your being here.
Thank you so much.
Tonya Winders and Caroline Blom will present a 90-minute NCQA webinar on high-quality asthma care Wednesday, July 23rd at 3 p.m. Eastern. The title of that event is Improving Asthma Outcomes. The event is free, and you'll find a registration link in the show notes and on NCQA's homepage, ncqa.org. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.